So many of you liked the reviews that I did on episode number 1 for Pitt that I'm back here with you doing episode number 2. Let me know what you think. Okay. Looking at Robbie and his personal protective equipment is definitely giving me flashbacks. I have PTSD from when I took care of patients with COVID at the hospital in 2020. It was a really strange time. We wore these hooded protective equipment, and I was fortunate and lucky enough to work in a hospital that did have enough PPE. I remember I actually filled out a living will, and I have like an advanced directive and a living will all because of COVID, because we didn't know what was going to happen, what the virus's effects were. So it was a really scary time. I remember that vividly now looking at his uniform.
I'm still waiting on.
Did you order the EKG?
The nurse suggested it to rule out any cardiac issues.
Well, good call on both your parts. Nurses know what they're doing. Never hesitate to listen to them.
So true. Nurses are incredible allies in the hospital. They spend the entire shift, their 12-hour shift, at the bedside. And so they kind of have a lot more information that we need as doctors. We round, we talk, we listen, we order tests, we write notes, and then we see the next patient. But nurses are bedside and they're incredible allies. And in a situation where the doctor and the nurse have excellent communication, the whole patient's stay goes smoother and the whole hospital runs smoother.
Yep.
The son and daughter of Mr. Spencer from assisted living, they're here.
Okay, I'll be right there. Your father has pneumonia.
I think it's important to mention what assisted living is right here, because I learned all of this only after being a hospitalist. There are different types of places that senior citizens can live. One is called an ALF, assisted living facility. One is called an SNF, a skilled nursing facility. And another option is acute rehab, and another option is home with home care. At the end of a progress note, when we're delineating all of our patients' problems for the hospital stay, the second to last is always DVT prophylaxis, and then the last and final problem is disposition, which means, what is this patient's disposition? Is it a guarded prognosis? Is it a good prognosis? Is it unclear right now, unclear prognosis? And when they're discharged from the hospital, how many days do we think they'll be here, and where will they go? To what support, or do they need support at all? All of that disposition is so incredibly important to plan for, and people really want to know how long they're staying in the hospital pretty much from the second they enter. And although we can't tell exactly how long people will be there, we can plan for it. So we have case management huddles every day, and we go through each patient, and the doctor shares their diagnosis, where they came from, their diagnosis, how long they're anticipated to stay in the treatment plan, and then where they might anticipate their needs going home. A lot of elderly people unfortunately can't go back home after being hospitalized for pneumonia or UTI or sepsis because they've been now bedridden for a few days. And even though we order physical therapy in the hospital, it's still not that much activity, especially if the patient's not self-motivated. And as we know, elderly people aren't that motivated to get up out of bed sometimes. So that was a long way to say assisted living facilities are for people who need help with basic activities, and skilled nursing facilities are more intense care. Like they have nursing support, like an LVN, maybe one RN for the whole floor, but maybe an LVN. And then acute rehab is for someone who just had a massive stroke that came in walking and talking and now has had a massive stroke and needs acute intense rehab. And they must be able to participate in 3 hours of aggressive therapy a day. So that's how they'll qualify for acute rehab. And acute rehabs are like mini hospitals. There's also another category called an LTAC, LTACH, long-term acute care hospital. And those are for people who are on breathing tubes, on trachs with feeding tubes, and those are intense. Home with home care, which means there are medical services brought directly to the patient's house. And the home services that can be brought to your patient's house are nursing or physical therapy. Yeah, but assisted living facility and skilled nursing facility, acute care, home with home care, all disposition from going home to the hospital.
And a condition called sepsis.
What is that exactly?
It means that the bacteria has spread from his lung to his bloodstream.
Sepsis is a really important, recognizable disease, and there was a whole sepsis campaign that took place in the past several years, which helped caregivers identify when sepsis happens. Sepsis literally is the body's overwhelming response to infection, meaning the heart rate gets higher, the temperature is higher, the respiratory rate is higher, and several of these 4 or 5 vital signs have to be off plus one documented source of infection, whether it's a urinary tract infection, bronchitis, and pneumonia, skin infection. Any one of these infections must be present for it to be called sepsis. And the reason why it is so important to recognize early is because it's 100% treatable as soon as we catch it in a time-sensitive manner. We give aggressive hydration intravenous fluids and antibiotics within 6 hours of them being recognized as having sepsis. And also, we get blood cultures and urine cultures and make sure there's no other source of infection. Because, like he just said, the infection could be so overwhelming, whether it's from the kidney, the lungs, the bladder, the skin, that it could seep into the bloodstream. So, getting blood cultures means we take tubes of blood and put them in a different container. And that is now grown on an agar or a media in a microbiome lab, which takes 24 hours, 48 hours, 72 hours to grow something. And if the blood cultures are positive, that's called bacteremia.
Is this his baseline?
He has good days and bad days.
But if he can get better in a week.
Baseline means what's the patient's normal day-to-day health? Is this the patient's baseline? Do they not talk? Do they shuffle around the house? Do they talk really well, take care of themselves, their activities of daily living? What's their baseline? That means the day-to-day state of health.
Actually, don't listen to Edwina Scissorhands here. If they can't cut it, surgery doesn't know how to fix it.
The contusion is high at the thyroid cartilage, so you just stand there looking pretty, ER Ken, and let me fix this.
Okay, you're going to be making a vertical incision to avoid the jugulars and the carotids. Good. If this was a crack that needed to happen in seconds, you could use a 10 blade, your finger, and a bougie.
End tidal CO2 is yellow.
Yellow is yes. Nicely done. Sew it in.
Okay, this is a cricothyroidotomy, which basically means they're putting an incision in the cricod cartilage of the tracheal rings. Normally, we would intubate someone, which means put a breathing tube through their mouth down the windpipe. But when someone has had a different anatomy and you can't do that safely, you have to go directly, between the collarbones. There's a little pocket that you feel. Sometimes I think people can hurt people that way too. So that is not where we're going with this video, but CO2 measures the carbon dioxide that you're breathing out. So the end tidal CO2 means that we know we're in the right place, we know we're in the right tube because we got end tidal CO2.
Okay. And get a lot of rest with all the monitors and all the blood tests. He might need to be sedated. He might need to be restrained because he'd be in an unfamiliar place with a very uncomfortable tube down his throat. Them as long as you want.
Nikki, it's Mama. I'm here, babe.
You're doing great, son.
Blown.
She said that like in a really funny way. She was just like, "Blown," and then walked away. Blown pupils mean there's no brainstem function. There's no brain function. Pupils are controlled by the cranial nerve number 3. And did I just make that up? I have to fact check that. That was my anatomy coming back from 2004 or 5. Anyways, there's no pupil function, meaning pupils are blown, meaning there's no brainstem function, which is not a good sign.
I can guarantee you that we will keep him as comfortable as possible if a natural death is what you choose.
But he's not your father. And he can recover from this.
What my sister means is that we're still deciding the best thing to do.
This patient was so well organized. He documented what he didn't want, and that documentation requires pretty organized system-based stuff, like he had to get it either notarized or witnessed. But basically, towards the end of life, or when people are suffering from chronic condition that they're facing mortality, kind of like I just told you how we were facing mortality during COVID, and I had to choose my life-sustaining or supporting treatments and go through these tough questions. There is a huge difference between doing nothing, which is DNR, DNI, do not resuscitate, do not intubate, and that's allowing a natural death. I used to try to explain it like this, a big topic that I'm passionate about, because when we come towards the end of life and transitioning of life, it's not just like do everything or do nothing. That does exist, but there are a few buckets in between doing everything and doing nothing, and I don't think that gets enough attention. So I'm going to try to explain it to you the best I can, but the 5 buckets in between doing nothing and doing everything are, say we do everything. A step below that is hemodialysis, which is renal replacement therapy, which means their kidneys are failing and they need dialysis. Is that a decision that that person would have wanted? A step below that are feeding tubes. Feeding tubes supply artificial nutrition. Just go through the nose, down the esophagus, which is the feeding tube, down into the stomach and stay right there. Or they go directly into the stomach from the outside. So those are feeding tubes. And the bucket below that is things like blood transfusions, which are relatively painless. They also come with their possible risks. Everything has a risk and a benefit, but after blood transfusions, there are intravenous fluids and intravenous antibiotics and medications. And very close to the mechanical life support that we do are intravenous medications called vasopressors. That is called a chemical resuscitation, like with epinephrine, norepinephrine, and dopamine. Those things simulate the blood pressure, keep the heart rate up, and are a form of life support. We have this huge difference between doing nothing, doing everything, and what are some things in between. When I talk to my patients, especially the ones that come in for their Medicare annual wellness exams in the office, this is not the hospital I'm talking about. The hospital is a really tough place to have this conversation because emotions are so high. And it's kind of one of the reasons I burnt out from being a hospitalist, because it was just hard to establish that kind of rapport and trust with someone that didn't know me. I wasn't their primary doctor. They just met me for that hospital stay. And when we could see things were shifting towards not doing so well, like Robbie can see that, what would your family member would have wanted? What did they not want? More importantly, do they have anything signed or not? And then adult children of the family members feel emotionally charged with this decision. So now I do my best to ask these questions as neutrally and as openly as possible, because the patients answer sometimes. They say, no, I never want dialysis. So like if that's an option, just no. Or some people say like, I'm not sure yet. I'll think about it when it comes to the feeding tube. Or I don't want to think about this. I have to talk to my spouse or my kids or whoever. And all those answers are valid and fine. But those questions are kind of really important to start considering.
Then I can't cry in front of the patient because no one wants to see their doctor cry. That's just a big red flag.
I am so curious as the audience what you think. Is it a big red flag when you see your doctor's eyes tearing up with you in pain for your loved one? Or is it like, you're not supposed to have that reaction? Don't be with me in this. Keep your eyes on the chart and the numbers. I have definitely vacillated with this topic. I don't know if you can tell, but I'm really sensitive and I am an empath and I care deeply. And sometimes I don't, and I get called out for not. But it's a really, really, really tough job. And when I do care a little too much, it wipes me out. I don't believe it changes my medical decision making. I still would make the same decisions and empower my patients and their families to make the same decisions. But is it a big red flag when you see your doctor crying? Let me know.
Patient tested positive for rats.
I know this is scary and stressful.
Oh, you. This is my son, and nobody is touching him.
Whoa.
Woo! That is a full-blown mama bear fear-driven response. And mama bears get scared and protective, and I could see that. It's not supportive in a hospital setting. You gotta keep it under control. Like, no, it's so hard, but basically ends up interrupting care and delays care, and there's just no room for like high-level emotions like that, whether it's anger outbursts or sadness or fear or whatever. I love the helicopter shots. This show nails it all. It's not just the cinematography, the scenes, the outfits, the set design, the way they hang up fluids, the way they attach the laryngoscope together, the way they make an incision. This show nails everything.
Dr. Santos, what are we worried about?
Rhabdomyolysis from tissue damage can kill the kidneys. Ongoing risk of cardiac irritability.
Excellent.
And savage.
Okay, rhabdomyolysis is a relatively common condition in marathon runners and people who work out excessively without drinking a lot of water or hydrating appropriately. Even when I ran a marathon, it definitely caused rhabdo. I had to take like a certain type of fluids, and I went to my own ER that I worked in, and they hydrated me, and it was a whole thing. But rhabdomyolysis is muscle breakdown. As simple as that. And muscles are made of proteins, and sometimes your kidneys can't filter those proteins in the bloodstream, and it causes kidney damage. And then that's acute kidney damage that gets better over time. It's called acute kidney injury. It's a very common condition.
Classy, bougie, ratchet, sassy, moody, nasty.
Oh my God, is she singing the Beyonce Megan Thee Stallion's Savage? I love that song. She is savage.
GSW just got dumped by homeboy ambulance.
Okay, you got this?
Mr. Milton? Hey, Bennett, wake up for me. Oh, shit. I need a little help here!
Ah! He probably had a massive heart attack. Bummer.
I'll see you back in triage once he settles down.
Yeah.
The reason why I said that is because he probably said he had gas pain, but gas pain can also be a symptom or sign of a heart attack. And what he needed was a troponin and an EKG and probably a cardiac monitor.
Let's take this off. All right, hang in there, Ian. This should really help with your asthma.
That guy who can't breathe well is tripoding, meaning I don't know what the shape looks like, but basically when your hands are on your knees because you can't breathe, you know, when you're like running after a sport in the field or whatever, and like you put your hands on your knees because you just can't breathe that well. I don't know why, but as humans, we tripod. And so that's a sign of like inability to breathe properly. The thing they're giving him in his hand is called a nebulizer treatment. It's a tube that delivers an aerosolized, vaporized medication that gets inhaled by all the tiny little bronchioles in the bottom of the trachea. So it's very cool. Our trachea is shaped like an inverted tree trunk with several branches. The tiny branches are called bronchioles, and the bronchioles meet with air pockets that are lined by little tiny blood vessels called capillaries. So in the capillaries, the blood meets the air, meets the tube that's delivering the air, the bronchiole. That is called a gas exchange. And that is where the oxygen and carbon dioxide get exchanged. That's essentially the reason why we can breathe. So the nebulization opens up the airways, and it's usually a beta-2 agonist, an antimuscarinic. Both of those will open up the airways.
He was a stubborn son of a. He would never have given up on either of us. We're not giving up on him.
You're absolutely certain you want to put your father through this after everything I've told you?
For healthcare.
Just said he was a stubborn son of a. Adult children often think that they're giving up on someone when they allow a natural death, and it sucks. It's a bad feeling to have for them and for the person hearing it, because the truth is, as much as health is in our control and we own our health, we own our future, there's a lot of health that's nuanced that's not in our control. So she's just taking on a lot of pressure and projecting it onto Robbie also.
If not, we can talk to your hospital attorney.
Please don't tell me you're going to intubate that poor man.
It's what the family.
And then the
wants.
judgment from the colleagues.
I explained all that.
Especially when they're going to give sign out. When the ER is going to give sign out to the hospitalist or the ICU doctor and say, I have a 91-year-old man who came in bedbound from the assisted living facility for sepsis with pneumonia. We intubated. The first question everyone's going to be like, why?
If I co-sign, we can override their durable power.
Ooh.
They're threatening to go to the hospital attorney.
Let them. Call the ethics committee. They'll agree with us. Activity.
Those people need some hope.
False hope.
Hope is hope.
Is it? What are we praying for miracles today?
Oh, well, that's interesting. Doctors have difficult decisions to make between adding time to someone's prognosis or sharing the devastating details of their prognosis versus making immediate decisions to reduce the suffering that people might go through. Eating healthy with a crazy schedule is pretty tough. That's like me as a healthcare professional and you as a busy professional. That's why I made this video down below to give you tips and tricks on how to eat healthy with a crazy schedule. Be sure to check it out, like this video, subscribe for more of this content, and let me know what you think. I'm making content just for you. And as always, own your health, own your future.